Good morning, Professor and colleagues. Today we'll discuss improve the quality improving programs in dialysis patients, focusing on the anemia management. Our agenda will be the quality improving program and how to improve the service in the dialysis units, how to calculate the performance score, the difference between the cost and the quality, and how to manage the best quality in the units. Lastly, we'll have some information on the differences between the generic and the biosimilars and the hemoglobin variability in end-stage kidney disease patients. So the quality management system is a global system that depends on the clinician and the recording system of individualized patient data, including the clinical situations, laboratory investigations, the dialysis modalities, the intradialytic complications, and the achievement. And the clinical performance monitors, the CPM, is on 3 stages. Stage 1 is how to monitor the patients, and then how to score the clinical as well as laboratory findings, and if failure, how to improve. And recording and monitoring of different parameters will give a definite score. That's your achievement. Then finally, you plan a program for improvement with each domains applied and the percent of failure, achievement, and the improvement program. So you can monitor and calculate the total performance score. Then you got your own score, what's called the achievement, and then plan for improvement, in particular, the percent of failure. Lastly, some centers are using quality incentive program. The payments and reimbursements depend on the final score. For example, if you look to the DOPS, either monthly or quarters monitoring of patients with different parameters. That includes erythropoietin stimulating agent use, looking to the iron profile, target hemoglobin reaching, the variability in hemoglobin as well, the intradiuretic loss, the ultrafiltration rate, the prescribed blood flow, the QP, the vascular access type, either native arteriovenous fistula or a catheter with advantage of the arteriovenous fistula, and adequacy of therapy. So TPS or total performance scores are calculated by different domains. The domain of clinical measurements with the vascular access type as a subdomains, urea reduction ratio, adequacy, anemia management, bone mineral disease, ultrafiltration rate applied. And additional domains like safety measures, example, the drawbacks of blood transfusion, how you are managing the unit with infection control policy, water treatment, reporting, and the virology with seroconversion. And if you have an example of the anemia in chronic kidney disease, the Japanese review, it has been shown that in many literatures, the humanistic burden on patients with anemia undergoing hemodialysis with a prospective observational studies found that patients with hemoglobin, low hemoglobin below the target have lower physical and mental component summaries of the kidney disease quality of life than patients with the target hemoglobin. We all know that lower hemoglobin predisposing for cardiovascular, cerebrovascular diseases, quality of life, morbidity, and mortality as well. So the effect of dialysis on blood hemoglobin is well known, and we have to identify the most appropriate hemoglobin level with maximum treatment with ESA therapy. increasing evidence available about the impact of ESA on varying endpoints, including morbidity, mortality, and quality of life, with the differences in hemoglobin variabilities and the fluctuation. This is a very important issue when you are using ESA and interchanging the doses or the brand by generics. You may have variabilities and fluctuations in the therapy. And if you are using dialysis in anemic patients, it's a very big pain because the difficulty of maintaining patients with a narrow range of hemoglobin, that's the fluctuation, how much appropriate administration of ESA, the type and dose, with the safety and efficacy profile, how to monitor the hemoglobin level and the iron profile. When you are using generics versus cost-effective treatments, you may pay much more when you are using generic because the comorbidities increasing if you don't have the target hemoglobin or have a fluctuation in hemoglobin level. And finally, the quality incentive program, the payments for the service according your final score. And this is a graphic presentation of both how much reaches the target hemoglobin and well, the fluctuation of hemoglobin with different therapeutic treatments. The hemoglobin variability and all-cause mortality in hemodialysis was concluded that based on current evidence in meta-analysis, there is an association between hemoglobin variability and all-cause mortality in patients receiving hemodialysis therapy. Example of the quality control system as well as the incentive programs, payments, controlling that like in the centers for the Medicare. And it's calculated based on different domains and subdomains, like total performance score for the clinical adequacy, hypercalcemia, ultrafiltration rate, as well care coordination domains like hospitalization ratio, standard readmission ratio, clinical depression and screening, and the percentage of prevalent patients waitlisted, with a safety domain including bloodstream infection, dialysis events and complications, as well medication. So this is the 100% of the total performance scoring that reimbursement will be decided according to the achievement of each centers. So the dilemma of the cost and the quality, you cannot decrease too much of the cost to get the best quality, but you can manage the quality based on the cost-effective way. So sometimes you decrease the cost, but you cannot get the best quality because of the comorbidities that coming from inadequacy or inefficiency of the treatment. First, to start with how to do a tender and description of the goods and service to be procured with technical specification here is indicated to manage different specification of each drugs, conditions of the tender, technical qualification and experiences, license, legal or financial conditions that ought to be met in order to be eligible, evaluation criteria outlines how your submission will be assessed and evaluated. For example, in case of anemia, how many patients reach the target hemoglobin. So technical specification, qualifications of the samples, preparing a reporting and submission before going for tendering and purchasing. The cardinal four stages of global improvement: the quality, the efficacy, the safety, and the comorbidity. So you can increase the quality of the drug, increasing the efficacy, increasing the safety, and subsequently you will decrease the comorbidities from inefficient therapy. Of course, price is an area of evaluation, but does not necessarily mean that the cheapest price will win the tender. So we have to look on the fitness of purpose, maintenance and running cost, quality, environment and safety consideration, capacity of the supplier, and the stability of the drug as well, which is not in many drugs. You cannot find a stable product and effectiveness all the time, and the payment terms. So does it still the cost affect the quality? Definitely. When you are decreasing the cost, you may not have the best quality, but you can reduce the cost by giving the effective drugs, so decreasing the overall comorbidities and improving outcome. More healthcare service for more patients for sure. And it seems like that the quality level of minimum quality and cost, you can reach it, and we can lower cost and maintain or even improve the quality. So you can take the best medication that improves the overall health care. So the minimum cost with the optimum quality is our target. Healthcare costs in chronic kidney disease are variable between populations. In developed countries, it's about 60,000 USD per year. The cost of dialysis is exceeding nowadays, but if you, for example, decreasing the cost of dialysis by improving the hemodialysis prescription. So if you improve the hemodialysis prescription, you will need less drugs to treat for blood pressure, for example, for anemia and others. So this is example how to decrease the cost by improving the service. And reducing the cost of chronic kidney disease while delivering quality health care, a call to action. And social cost of the care for patients with chronic kidney disease, including the dialysis as well as the drugs, is variable according to the societies and the countries, looking for different parameters in the treatment, either dialysis per se or drugs for bone mineral disease or laboratory testing. The budget and payments. The cost-effective hemodialysis therapy, type of treatments, quality of therapy, as well as the drugs, monitoring of patients, all of that improve the outcome. Should difference in payment affect the type, the quality, the outcome of hemodialysis and the medication taken for patients on maintenance hemodialysis? My answer is yes. Financial and reimbursement issues have been identified as the most important non-medical factors in dialysis modality selection in countries around the globe. So costs are generally described in four categories: the direct medical cost, medical disposables, capital cost of equipment, direct non-medical cost, building cost, facility utilities and other overhead costs, intangible costs associated with pain, suffering, impairment of the quality of life, and indirect costs, productivity loss of patient and their family. So if you decrease the cost, you will affect mainly the patient's outcome, pain, depression, quality of life, and indirectly cost, productivity, how much they can work, and loss of patient and their families. So the reimbursement of dialysis is very important. It is different in different countries according to the GDP of each country, and sometimes this is related to different therapies like dialysis home or in-center CAPD, with a specific element included. For example, ESA. Some countries are paying for ESA and some countries are not paying for ESA. So if you are paying for ESA, you have a better outcome. Therapeutic thresholds affecting the reimbursement, including here the adequacy and the hemoglobin in the United States and Germany. So this is one of the best example is the reimbursement of payment according to the patient's outcome. So the clinical practice guidelines like Egyptian guidelines and international guidelines is translated into a clinical performance measurements and a total performance score. That's the difference between both of them. The patient reported outcome could be reported publicly, and it is mainly related to the quality of care and how we can monitor of the service. So assessing the patient, opportunities for improvement, and the quality improving project to achieve the better result. That's the 5-star centers with different reporting, clinical, and safety measures. So the clinical measures by every month or every quarters per year, it will be like that, how much patients are in different categories, in adequacy, in infection, in anemia, in hypercalcemia, and this is graphic is repeatedly every month or every 3 months. So the CPM defines the patient's experience of care with quality measure for dialysis. Structures, process, and outcome of health, the 3 cardinal cornerstones in the quality of treatment. How do you do the structure and how you are giving the drugs in the process or the treatment, then you can measure the outcome of healthcare. Indicators like health status of the patients, adverse events, mortality and morbidity, health-related quality of life, and patient satisfaction. So structures is important in dialysis unit like water treatment, hemodiafiltration machines, process, how much you are giving the patient the care, treatment with proper ESA to give the target hemoglobin is one of the major processes. Phosphate binders and the outcome, survival, hospitalization, comorbidities, heart failures, from example, inadequate dialysis or inadequate medications, comorbidities, and laboratory work. Example of quality and the metric a patient reported ability to work. This is a good example for the cost and the quality. If you pay a little bit higher cost, you got the best quality, and the likelihood of a patient reporting ability to work increase with the number of clinical performance. So you paid a lot in the adequacy of dialysis and anemia management, but still you have gained a success of ability of work the society needs. Coming to the third part of the talk is the generic versus brand. What are generic drugs? Generic medication are chemical copy of the original brand. Most active pharmaceutical ingredient and generic medication are made outside the US in countries like China, India, and various other countries. Generic medication must meet the same quality standard for approval by the FDA as a brand name or the European standard. Generics have to prove they are bioequivalent, trusted source to the brand version. Bioequivalence means the generic works the same way and provide the same benefits in both dosing and adequacy. FDA must approve the generic drug before it can be marketed. To gain FDA approval, a generic drug must be obtain the same active ingredient as the innovator, come in the same dosage, be administered by the same way, be identical in strength. This is very important to have the perfect efficacy, as the same condition of use meets the same standard for identity, strength, purity, and quality. For FDA as well for the European certificates, we have to follow that for any generic drug to meet the adequacy of therapy as well for the brand. So all drugs in the FDA and as well in many of the other standards, generic biosimilar should be approved. If you look to the different phases of FDA, even generics and biosimilar should follow the phases of FDA to be approved. Otherwise, they will not be approved either as a generic or a biosimilar. Going from phase 1, phase 2, phase 3, phase 4, then FDA approval results. Other than these phases, drugs could not be even considered as a generic. Do generic drugs compromise on quality? A new study raises questions about whether they are truly equivalent to the brand name version, and concluded that understanding the generic approval process before considering any drug as a generic. So we have to ask about any generic drug, the way and the process of approval. Safety and quality of generic drugs, a never-ending debate fostered by economic interest. Generic versions are still often debated with their safety and efficacy compared with their originator, continually still questioned. This is hard to accept, particularly in developed countries that for decades have had clear rules in place on the characteristics of generics. So a brand medication is the innovator or pioneer and gets patent and exclusively protection, so generics cannot compete right away. Generic medications must meet the same quality, strength, purity, standard as brand, so they have the same benefits and effects if they do so. Generic and brand medication don't look the same. Generics may have slightly different inactive ingredients. They don't affect how the medicine works. Many people have concern about switching to generics and prefer brands. Some doctors also have concerns with certain medications. Concerns when using generics: the cardinal 5, worsening of symptoms or condition, side effects, effectiveness, safety, and equality. So these are the 5 cardinal concerns when you are using generics: the disease condition, side effects recording, effectiveness, its safety, and the quality. Coming to the biosimilar, we don't have in Egypt biosimilars, but in general, biosimilars mean it's a biological product, it's not identical, it's a highly similar to another already approved, but it is not a copy or generic, and should meet the standard and efficacy and safety as well. But we don't have in Egypt biosimilars for that. Biosimilar versus originator. The biosimilar recombinant hemoerythropoietin induces the production of neutralizing antibodies. So the one of the drawbacks of biosimilars, as well in the others non-patent drugs, can induce a lot of complication, especially in the erythropoiesis system. The complexity of manufacturing process for these recombinant proteins, however, can result in altered properties that may significantly affect the patient safety. With different studies found that pure-red-cell aplasia, indicating the loss of erythroplasts coming from drugs and generics or biosimilars. That's why hemoglobin variability in erythropoietin treated hemodialysis patients with a stable hemoglobin in hemodialysis patient first for the trees at 12-week pilot observation studies using the same dosing and same medications can maintain the hemoglobin at the same level by the same doses. For example, here in this study, the dark-whiting doses. And if you look for the cost-effective program, for example, here the RNS with dark-whiting may allow the reduction in hemoglobin maintenance dose when converted from short-acting generics treatments to the brands. You can have better outcome and you can have a more stable hemoglobin level. Less frequent dosing provides operational efficiencies. For example, the long-acting erythropoietin stimulating hormone can decrease the overall cost of ESA twice weekly or thrice weekly, and ESA once or every 2 weeks. So the dialysis unit and pharmacy cost per patient per year will be decreased by the manpower as well for the patient's requirements. The efficacy gains of using weekly administration in U.S. dialysis centers potential value for typical dialysis facility, switching from thrice weekly to once weekly or even every 2 weeks by decreasing the manpower and the staff times and labor cost works. So in conclusions, giving the priority of quality of service, the cost should be affordable and effective. Not only affordable, but should be effective as well. Using the highest quality treatment decrease the overall costs by decreasing and ameliorating the comorbid conditions and complications that cost higher with least healthcare outcomes. Scoring system is a must to measure the accuracy and accurately the outcomes of the patients. Thank you very much. Awaiting for questions and answers.